Good afternoon, everyone. Thanks for attending, and thanks, Dr. Khalid and the committee for organizing this excellent meeting. I had really big three challenges while I'm talking to you. Number one is you not falling asleep. It's too much rheumatology for one day, isn't it? Too much, I agree. But number two is speaking about that many drugs in rheumatology nowadays, with how complex they are. And actually what makes us unique in rheumatology is the drugs that we use. And fitting that in 30 minutes, that's like an impossible. So I put a timer for myself. And a third thing is to make it interesting enough, because things can be too much details. And as a rheumatologist, I can't really stop myself speaking about cytokines. It's just in our genes, so we can't stop that happening. But anyway, in rheumatology, I remember my professor, when I was doing my training, his MD or PhD was about physiotherapy, or I think he was of NSAIDs in rheumatic diseases. So for a while, we didn't have that many drugs where, since the 1950s, yes, we had the steroids, and then we started having disease-modifying drugs such as methotrexate, and then sulfasalazine, chloroquine, gold. And we've carried using the same stuff for a while, for nearly 50 years. Without much advance and during that time we sort of worked on the outcomes and how to measure the diseases and how to improve, measure damage and extra. It took until year 1999 or 2000 when the biologics came, and we call this the biologic era. That's, well, many years after the dinosaurs era, but we had the TNFs coming first of all. We started with infliximab and etanercept. Etanercept actually was the first. And then adalimumab and anakinra came, and then we have a gush of other mode of action. Rituximab was a B-cell inhibitor. Then we have abatacept was a T-cell modulator. Then we have more anti-TNFs. And we were happy. Then we have IL-6 inhibitors. There are more mode of action. And then we have what we call small molecules or targeted small molecules, which are JAK inhibitors. And that has been out for the last, I would say, 10 years. Nowadays, for just one disease, rheumatoid arthritis, we've got about 19 disease-modifying drugs, including the well-known disease-modifying drugs. That's the methotrexate, leflunomide, sulfasalazine. We've got one anti-malarial we like to use a lot. And steroids, of course. We've got 5 anti-TNF, including adalimumab, cetrorelizumab, etanercept, golimumab, infliximab, and they're all available in the UE. We have co-stimulator inhibitor, which is abatacept that work on the T-cell co-stimulator, work on T-cell inhibition. We've got IL-6 inhibitors, tocilizumab, that's available here, but we don't have the sarilumab in the UE. And we have the B-cell inhibitors, which is rituximab. And we have JAK inhibitors. And among the 5 available JAK inhibitors, we've got 3 available in the UE. When it comes to psoriatic arthritis, it's not less. We've got IL-17 inhibitors, IL-23, IL-23-12, PDE4 inhibitors, plus 2 of the JAK inhibitors are licensed for the use in psoriatic arthritis, and 5 of the anti-TNF all can be used in psoriatic arthritis. So another 18 drugs, and each one is unique, of course. And then we have another drugs that we could use for myositis, as you had from the talk. We can use for lupus, connective tissue diseases, including, again, conventional demands such as azathioprine, mycophenolate, cyclosporin, tacrolimus. Then we have biologics such as PLIS inhibitors and interferon inhibitors. Are you asleep already? Okay, let's get some excitement. Let's start with some questions to wake you up. So we have Mrs. Saleh here, who is known to have rheumatoid, were admitted with jaundice. Her ALT was 4,000. Which of the following drugs could be responsible? Let's raise hands here. Who thinks it's methotrexate? Who thinks it's sulfasalazine? Who thinks it's leflunomide? No hands. Who thinks it's actually methotrexate and sulfasalazine? Both can cause high ALT. Yeah, who thinks that all of them can cause high ALT? So we've got like 10 people, yeah? And some of you don't really know what are these drugs are, I think. Could be the case. I didn't know before I became a rheumatologist. Anyway. Okay, let's go to Mrs. Zeroni. We know the answers later, by the way, don't worry. Mrs. Zeroni, who was admitted with sepsis, and I apologize if anybody name is surname is Zeroni, but just a random name, admitted with sepsis and was found to have a very low neutrophil count, which is like 0.01. You diagnosed her with neutropenic sepsis, and when discussing with family, you discovered she has rheumatoid. And on rheumatoid medication, which of the following drugs could be responsible for neutropenia and neutropenic sepsis? Is that methotrexate? Could be the sulfasalazine? Could be the leflunomide? Could be methotrexate or sulfasalazine. Could be all of them. Nobody thinks all of them, okay? Or one person, okay. Last question before we jump or dive in our talk today. So we've got Mrs. Khan, who has swan neck and Botany's deformity, who was admitted with TB. You discovered she is on rheumatoid medication. Which of her rheumatoid arthritis medication could be responsible for her latent TB reactivation? Could that be the rituximab, the B-cell inhibitor? Could that be the adalimumab, the anti-TNF? 5, 6, 7 people. Methotrexate? Someone. Abatacept? No one. Sulfasalazine? No one. There are more votes with adalimumab. Okay, let's start with the commonest drug that we use and we like as rheumatologists, steroids. Steroids started in the 1950s, and I call it the beautiful evil. This is how I imagine it. It's like marrying a very beautiful wife or husband. You got a nice honeymoon, and then your life become really problem. This is exactly what steroids do. Really good effect, but the longer and the more you have from it, the more problems you have. Interestingly, Philip Hinch, who was one of the earliest rheumatologists, an American guy, he got Nobel Prize for steroids and discovering the use in rheumatic diseases. So he was the only rheumatologist who got a Nobel Prize. Hopefully next is going to be Dr. Khalid Nakbi. I'm not sure. We'll see what he does, getting a Nobel Prize for discovering something new. But anyway, it has a magic effect. It could be a lifesaver, I have to admit, but it has significant side effects profile. So the weight gain, the uncontrolled diabetes in diabetics, the MACE risk, the osteoporosis. We use few forms. We like using the intramuscular depamedrone, methylprednisolone injection. Really work well. It sort of wean itself out from the system in 2 to 3 months. Doesn't needs much tapering. Side effects not really significant. And we could use triamcinolone, which is alternative. Some people call it Tricon here, or Kenalog, if you know what Kenalog. We could use prednisolone, oral tablets. We could use IV methylprednisolone, and we usually save that for really bad things like lupus nephritis or really bad flare-up of any disease, lung inflammation or something. Less commonly, we don't use IV hydrocortisone a lot. We use it sometimes if we switch patients from oral to IV while admission. If they got like an absorption problem or nail by mouth, we can just convert the dose from prednisolone to IV hydrocortisone. We're not really a heavy use of dexamethasone, not like our oncologist colleague who like to use it a lot, or some of my orthopedics in my hospital quite use dexamethasone for their injections. But anyway, if you look at the dosing, relative potency, the ones that we like to use, the middle ones, the prednisolone, methylprednisolone, or triamcinolone, they are 5 times the strength of hydrocortisone. Dexa is really strong, it's about 20 to 30 times. And the duration for action is much longer, of course, for Dexa, but it's intermediate. And you can see the dosing for Pred. The 1 milligram is not available here in the UAE, but we tend to have the 5 and 20. Well, for Depo, we tend to use 80, 120. You can use 40 for intraarticular injections. As triamcinolone, we've got the 40 and 10 milligrams available. So the concept when you use steroids, you need to use the smallest possible dose that's effective in your patient, the shortest possible term in terms, so don't really carry taking your steroids for a long time. It's not a lifelong drug. You have to, unless if there is a steroid deficiency, and give it from an endocrine perspective. You need to assess the need and assess comorbidities, because you need, before giving it, the dosing wherever, you need to see, are they diabetic? Was there ischemic heart risk? The last thing you don't want is you treat something mild and them entering with DKA or ischemic heart disease from steroids. In rheumatology, we've got exceptional cases with giant cell arthritis and polymyalgia rheumatica. We tend to use steroids a bit longer, for about a year and a half, 2 years, and we tend to taper them in a specific way. Like for polymyalgia rheumatica, we only start with 15 milligram and taper after 4 weeks, trying to taper by 2.5 to 1 milligram every 2 to 4 weeks. In GCA, we tend to start higher doses, like probably 40, 50, even 60 milligrams. And after 4 weeks, we taper by 5 milligram every 2 weeks until we reach 20. Then we taper by 1 milligram, 2.5 milligram until we reach 10. And then we taper slower. So so you see the dose, if you are below 20, it's not higher dose. So you are less stressful about the side effects, but still there's a possible side effects profile. Once you are on 10 milligram or 7.5 milligram, if you use the 7.5 milligram cutoff, it's probably more, let's say, evidence-based, and this is possibly a low dose, and the side effects are minimal. So one of the talks we had today was osteoporosis, and steroids are really bad in terms of osteoporosis. You can see the dose-dependent increased risk of fractures with steroids. Once you are on steroids, the risk of having fractures is really high within the first few weeks, and even goes with the age. So the older you are on higher dose steroids go up. So the higher the dose you have, the older you are. So you can see the difference of the relative risk of spine or hip fracture based on your the dose of steroids. So like this is like if you are at 7.5 is much higher if you are on less than 2.5. So it's really bad. So that's why once you put a patient on steroids and you think they are going to stay long term, you need to consider osteoporosis prophylaxis or treatment. And there is the International Osteoporosis Foundation has special recommendation that if you are a postmenopausal woman or men above 50 who started steroids more than 3 months on a dose that's 7.5 or higher, you need to assess for FRAX, probably DEXA, and if you think they got a higher risk, is you start prophylactic treatment. So please do that for any patient you think is going to start steroid for a longer term or higher doses. That's our lovely Nobel Prize winning drug, but now we don't like using it a lot. We use it mainly for bridging for other drugs. So we'd like to use conventional synthetic DMARDs, and unlike our dermatology colleagues, we're still using conventional synthetic DMARDs. We don't jump to biologics simply because they are very efficient and cheap to use. They're cost effective. And if you got your 60% of your patients achieving good response with really cost effective drugs, you don't have to spend lots of money, because that would be more, in terms of health economic, more cost effective. So for rheumatoid and psoriatic arthritis, we've got 4 main drugs: methotrexate, sulfasalazine, and leflunomide. We have hydroxychloroquine, and we might argue until tomorrow if it's actually a DMARD or just an antimalarial, because it's in classification, it's an antimalarial drug. Then we've got some other DMARDs that we could use for lupus, for vasculitis, myositis, and connective tissue disease, including azathioprine, cyclosporin, mycophenolate, cyclophosphamide. They tend to be slightly more cytotoxic. But the general concept for these DMARDs, they are immunomodulatory, and we like using this. We don't like using the immune suppressive term because it is really scaring to our patient. They could be immune suppressive if they are used in high dose or not monitored in a right way. But if you do it in a right way, they might just want to immune modulate the patient, not really suppress his immune system. Each one of these agents is unique, has a unique mechanism of action, so they are different. They're not the same. That's why if you use one that fails, you could use the other one. And what they do, they interfere with something in the pathway of the inflammatory cascade of the disease. So each one has specific precautions. There are a side effects profile, they need monitoring, and they need specialist prescription. So the last thing you need to do is like that doctor in my emergency room who had a patient who came with joint pain, and he prescribed him leflunomide and sent him away. So you don't want to do this, because this is absolutely a mistake. You'll see why. Because there are general precautions. Lots of these drugs, almost all, with the exception of hydroxychloroquine, can cause bone suppression, and that will lead to neutropenia with risk of neutropenic sepsis and subsequent death, thrombocytopenia, risk of bleeding, and of course anemia that could be problematic. They all come with the risk of hepatotoxicity, except the hydroxychloroquine. So we need to monitor them. So that's why when we start disease-modifying drugs, we need to really have a baseline bloods, which is full blood count, liver function test, and creatinine. And then do that after every 2 weeks for the next 6 weeks, then become monthly for 3 months, then become every 3 months, with the exception of leflunomide, where we like to give it into 2 months. So when to stop if the patient develops neutropenia and if the ALT go really high, so above the 3 times the normal. So let's speak about the commonest DMARDs that we use. Methotrexate. We like methotrexate. It's a horrible drug. Some patients don't like it, but we love it in rheumatology. I said it's effective in most of our patients and very cheap. So we've been using it since 1980s. It's the first line medication for our medication, and we use it as an anchor drug. So even when we add biological drugs, we tend to add them to methotrexate, and I'll tell them why. We like to start with things like 7.5. I'm more brave. I tend to start with 50 milligram and go up quickly to 20 or 25. And we tend to use folic acid. So it's a once weekly drug. And the folic acid used the next 6 days. So the more folic acid, from my experience, the less side effects. There are people who are using it just once a week, the folic acid, or twice a week, but I generally tend to use it 6 days a week, and I do see significant side effects with that. So actually, not many of us know how methotrexate works. We know it's about the antifolate pathway, but it's really complex, really bright the way it works. And as I said, we tend to use it with anti-TNF as well to improve the efficacy. So this is a very texty slide, and I do apologize for this, but what happens, just some general concept about methotrexate, is methotrexate orally is absorbed through protein-coupled folate transporter in the small intestine. And absorption could be an issue if the patient has an absorption issue. And you have to consider parenteric methotrexate, which is available, the subcut methotrexate. Yes, it's excreted through the kidneys, but it's not really necessarily nephrotoxic. But you could have side effects, more side effects if you have a renal impairment. So some of the drugs are metabolized by the liver, and 10% are excreted from the biliary system. But the drug really reached a peak plasma level after about 1 to 2 hours after initiating, and it takes 24 hours to accumulate in the cells, inside the cells. And what we need is to get whatever remaining outside with the folic acid. But what happens, it doesn't happen overnight. The more dosing you have, the more accumulation inside the cell. And the more accumulation, it does more action. That's why the drug can take about 2 to 3 months to take its work, and it needs really lots of patience to start working. So how is it working? Methotrexate, it's working through the folate antagonism pathway by reducing the purine and pyrimidine pools in primary human T cells, and subsequently reduce the level of ATP and GTP available to the T cells for proliferation and activity. So that's why it reduced the autoimmune processes. It sort of have something to work with also oxygen, reactive oxygen species, and in that way it increases the apoptosis of the T cells, the abnormal T cells. It works in methotrexate, reduce the chemotaxis of the cells, because through the adenosine pathway, and this is really important because adenosine is very important molecule in inflammation. It reduces the inflammation. The more adenosine, the less inflammation, because adenosine stops the neutrophils and other inflammatory cells attaching to the endothelial tissue, to the tissue. So imagine neutrophils like the Spider-Man having these hands to just attach to the walls, and whatever stops that sticky thing from their hands, they can't really attach anymore. So that's why adenosine is really important. And using methotrexate could actually stop the degradation of adenosine, making adenosine accumulate more, and that subsequently reduces the inflammation. We know that methotrexate is very important to use if you are anti-TNF, because the more if you are methotrexate, the efficacy to TNF is significantly higher. And it goes from sometimes 5% to 60, 70%. So it's very important to give, especially in rheumatoid arthritis, give methotrexate with anti-TNF. It works in 2 different ways, either through inhibiting the production of anti-drug antibody, and I'll mention about this in a minute, or through probably the synergic anti-rheumatic. Methotrexate does its work, the anti-TNF or biologic do their work. Or sometimes we know that methotrexate does enhance the apoptosis of inflamed cells, especially those where the anti-TNF antibody attached to, so make the cells die quicker. So that's enhance or reduce the autoimmune process. Well, here is very important. What's the side effects of methotrexate? The commonest to see from my experience is nausea, patient reporting nausea the following day after you take the methotrexate. They could have less commonly mouth ulcers, some hair loss, not necessarily significant, is one in and out now and again. But the things that worry us as clinicians is hepatotoxicity or bone marrow suppression. So for this, as mentioned previously, we need to do the blood monitoring, as mentioned, the same sequence. As mentioned about drug-drug interactions, you need to be careful if your patient comes with infection and give them trimethoprim or cotrimoxazole, Ciptrin, because that would increase the bone marrow suppression and increase the risk of neutropenia. Methotrexate is teratogenetic. You need to advise your young patient to have contraception, effective contraception, not just their way of doing it. Effective contraception before having methotrexate, and they need at least stop at 3 months before removing their contraception because it's badly teratogenic. Probably patients should avoid live vaccines when they are methotrexate, especially the higher doses of it. And if there's an infection, if you are in medical admission unit and you have a patient who are methotrexate. No, it's still going on. Why you stopped my talk? Yes, here we are. So I still have time. Okay. So hold in case of infection. So hydroxychloroquine is the antimalarial, really milder drug. It's the mechanism of action is unknown usually, but we usually use it more in rheumatoid and lupus. And the dose is 5. The maximum we like to use is 5 milligram per kilogram per day. And it's available in 200 milligram tablets. Doesn't have the blood monitoring requirement of the other DMARDs, but there is a possible risk of maculopathy and retinotoxicity, and that's why I advise patients, if they continue on them, especially if they've got risk factors such as old age, having renal impairment, if they has been using it for a long time, to have to check with their ophthalmologist every year and at baseline as well. Leflunomide, similar to methotrexate. The only precaution with leflunomide, it can increase the blood pressure. For this, we like to add the blood pressure in the monitoring. We like to do it every 2 months. Am I running out of time, apparently? I still have some.
Stop, Dr. Ahmed, because
it's very important. You gave me, as a panel, I'm sure you'll give me another 10 minutes.
2 minutes?
Huh?
Another 2 minutes?
Well, I'll have to run then. Yeah, give me 3 minutes and a half.
Okay.
Like, yeah.
It will be taken from a question.
Sugnayev. Let's, okay, give me a couple. Okay. Whose idea is this, switching the speaker off when...
We are behind
Dr. Khalid,
the
is that your idea? You're screwed, you know. Okay. This is sulfasalazine, similar thing. Mycophenolate, we use it in lupus. And again, similar. So all of them need monitoring because hepatotoxicity, different profile of side effects according to the drug. An azathioprine, before you start it, you need to test for TPMT, tripurine methyltransferase, because that if you have deficiency of that, you are more likely to have a bone marrow suppression. I have to run. Unfortunately, I don't like doing this, but biologics, many of them are available, different mode of action. It's like it's like a civil war. It's like the cells communicating through the interleukins, that they talk to each other. So what we need is simply in that immune pathway, we block some of them, so we stop them talking to each other. That's how we do with immune complex pathway, blocking this, blocking that, to having an antibody like this TNF, that's instead of attaching to a receptor and inducing an inflammatory pathway, you're just blocking it by having an antibody catching it and getting rid of it. And they are in different forms, different shapes, like our life and like our lovely faces here. We have nowadays biosimilars that are exactly like biologics, but just like a copy key for the original key. So they all open the same thing. They are significantly cheaper, especially with our health economics. They are important. But what we need to know that they are really complex, the antibodies, so they're not generics. That's why we call them biosimilars. It's like manufacturing exactly a copy plane to the little screws. So it's not like this is that generic aspirin. It's like making a bike. Okay, very complex for us choosing what biologic base, what disease, what background, what antibody, lots of things going on. Unfortunately, I have to run through this, but they are very expensive stuff, and that's why we really need to be careful before we prescribe them. We need to test for hepatitis C and B, HIV, and quantiferon. We need to monitor them as we do, but just every 3 months. There's lots of side effects, and possible precaution side effects, TB reactivation with anti-TNF, adalimumab, for example. Demyelination if the patient got MS. So we need to really not to give anti-TNF if the patient got MS. There is increased risk of fungal infection for IL-17, bowel perforation, hyperlipidemia, IL-6. So each one has its profile that you need to be aware of. JAKs, I'm going to run through JAKs. I'm not mentioning about JAKs much, but there are small molecules now. They're really advanced. They're lovely to use, but they could come possibly with risk of increase of MACE, DVTs, and shingles. So the patient comes to you in ER or medical department. Shingles probably is the JAK if they are using one who end up with tofacitinib, baricitinib, beep things. Okay? And again, we like to test for hepatitis before we start and for HIV and TB. Anyway, the answers for your questions, let's answer the questions. I'm done. Let's answer the questions. So the answers for your questions are, if you brought the slides back again. So, Mr. Salhi, all of them, as you could tell now, they could cause hepatotoxicity, all of them could cause neutropenia, and all of them, but just anti-TNF really is increased risk of TB reactivation. Thank you very much, and apologies for overrunning. Thank you.